Perfect. Thank you so much. So good afternoon. I'm seeing lots of new faces or names at least. So I am Shania Ormia, viral hepatitis, Director of Viral Hepatitis Prevention and Clinical Services at the state of Tennessee. We're really happy to have everybody here today. And I will be acting as our facilitator for this session. So let's go to the next slide. So today's agenda will include introductions and announcements, a didactic presentation on hepatitis C virus and evaluating cirrhosis by Dr. Chastain and Dr. Alfaro Cruz, 2 adult case presentations, a Q&A session, and some closing remarks. So first, some in-chat introductions, as well as some brief announcements. Before we get started, if you don't mind to introduce yourselves in the chat. So in the chat, if you'll just add your name, your role, your organization, and whether or not this is your first echo, we would be so excited to meet you. I see some people starting to put that in already. And those of you just joining, feel free to continue introducing yourselves as well. Next slide. So a few just quick reminders I want to highlight that you probably are already aware of since you were able to join this session, but I know it's been a little bit of a change as we transitioned over to the Southeast Age Education and Training Center as our accreditation body, but we're very grateful for this partnership. And so I really want to make sure that everyone takes just a couple minutes to ensure that they're signed in. This will help with getting your continuing education credits if you're interested, as well as showing your participation and ensuring that you receive future communications too. So this is a requirement for our accrediting body as well. And Clover or Dr. Chastain, do either of you have anything to add?
I'll just chime in, and like you said, it is a requirement for the accrediting body. This is what helps us provide this sort of training whenever we report back to HRSA. This is what we get our attendance information on, and also let you all provide us with information on what sort of trainings you'd like to get in the future. And so keep an eye out on your email. If you're wanting to do the continuing education credits, you'll have to fill out the evaluation. And if you have any questions about that, feel free to reach out to me. Thanks.
Perfect. Thank you so much, Clover. And Clover actually dropped the link in the chat too for those that need it. So thank you so much. And we will circle back to at the end of the session too. Next. So please turn on your video and mute yourselves unless speaking. We'd love to see your faces as we're talking. It's really great to be able to speak kind of to the audience in that manner and really interact with one another. So feel free to come off mute though as we continue and ask questions and things as well. We're happy to have that interaction. And then Anastasia, did you happen to notice anybody joined by phone?
Nope.
Perfect. So please never discuss PHI and treat everyone with respect as well. So that wraps up the kind of announcements. So I'm going to pass it off to Dr. Chastain and Dr. Alfaro Cruz. If you all will just say next slide when you're ready, that would be great. So who's going to kick us off?
Okay, I will be starting. So good afternoon, everyone. Thank you for joining us here today. Today you're going to get a double feature. With Dr. Chastain and myself, we have prepared this presentation to talk about hepatitis C virus and evaluation for cirrhosis. Next slide, please. Before we talk about our objectives, I have to report that we have nothing to disclose, no conflict of interest. So let's start with this. Now, at the end of this session, we want to have, our goal is that learners are able to identify symptoms of advanced liver disease, identify some of the signs of chronic liver disease, contrast at least 3 methods of liver fibrosis staging, and recommend appropriate evaluation of cirrhosis after sustained virologic response has been achieved after treatment with hepatitis C. Next slide, please. Oh, well, there's our disclosures. As we said, we have no conflicts of interest or disclosures to report. Next slide, please. So let's start with what is cirrhosis, right? We know that cirrhosis represents a late stage of progressive hepatic fibrosis. And this is actually characterized by distortion of hepatic architecture and the formation of regenerative nodules. This is actually considered most of the time irreversible when it's in its advanced stages, at which point the only treatment option may be actually liver transplant. We know that patients with cirrhosis do have a reduced hepatic function and are at increased risk of a different variety of complications, and their life expectancy is markedly reduced. It's associated with increased mortality and morbidity. Next slide, please. Now, there are numerous causes of liver disease that can actually end in cirrhosis, and we have divided them what we tend to see most common in adults and what we also tend to see more in children. And these causes can be either by causing chronic hepatic inflammation or cholestasis, which it's tend to actually being seen more in children. Now, the most common causes of cirrhosis in the US for adults are usually chronic viral hepatitis, Hep C and Hep B. We also have been seeing more alcohol-associated liver disease, as well as non-alcohol-associated fatty liver disease, which it goes by the acronym of NAFL or NASH, and also hemochromatosis. In children, it tends to be a little bit different. Usually, we tend to see more cholestasis etiology, the reason why they tend to get cirrhosis, starting by biliary atresia. Other causes like genetics or metabolic syndromes can also cause cirrhosis in children. Viral hepatitis is the third more common cause, and autoimmune hepatitis. Next slide, please. In adults, it's estimated that approximately 20 to 30% of those infected with Hep C will actually develop cirrhosis during that 20 to 30-year period after actually acquire Hep C. Now, in children, this is actually less likely. Progression of chronic hepatitis to cirrhosis is very unlikely. And actually, one sample study did show that in patients who had chronic Hep C, about a mean age of 10 years, only 2% of those actually advanced to cirrhosis. And I have to mention that there were other associated factors too with that chronic Hep C infection that may have contributed to actually develop cirrhosis. So as you can see, there's a significant difference in the percentage of people who can develop cirrhosis from hepatitis C. Next slide, please. Signs of we're going to see different signs of advanced liver disease, and they can range from some patients can be asymptomatic to becoming completely symptomatic and decompensated. Others can have upper GI bleedings, ascites. They can have hepatic encephalopathy, or even presenting liver failure when they come into the hospital for the first time. And some of them can have also pulmonary complications, right heart failure, or even kidney failure associated with advanced liver disease. Now, if we can go to the next slide, please. The signs of chronic liver disease, as we were mentioning, may vary, right? Some may actually include jaundice, ascites, as we were talking a little bit early. Physical examination may reveal spider angiomata or palmar erythema, telangiectasias. Some patients may actually present with gynecomastia, splenomegaly, as well as digital clubbing or asterixis. And some patients can actually present with encephalopathy. Now, we also have to remember there are some non-specific symptoms too that may be associated with chronic liver disease, and that includes anorexia, weight loss, weakness, or fatigue in these patients. So it's very important to know that we may not see all the more typical signs, but it can start with non-specific symptoms as well. Now, usually in these patients, we're going to have certain laboratory anomalies that may actually help you to see if there is advanced liver disease. And those can include elevated serum bilirubin, abnormal aminotransferase levels, elevated alkaline phosphatase or GGT, a prolonged INR time or a prolonged PT time, hyponatremia, hypovolemia, and thrombocytopenia as well. So those are things that you have to be aware that can be associated with chronic liver disease. Next slide, please. There you go. So we're having a little bit. So why is the importance of staging? So first of all, it's going to help us identify those patients with greatest need of therapy, right? We have discussed in previous sessions that the presence of cirrhosis or not is not going to delay treatment for Hep C, but this is actually going to help us identify those that need more therapy. Then we need to identify those patients with cirrhosis-specific care. As we have mentioned in the past, some of them may require to have ultrasounds every 3 to 6 months, even to have endoscopy done at a routine schedule to make sure we are screening for varices. And it's going to help us triage resources. Can we give another enter, please? And so the type of stagings that we're going to use are going to go from liver biopsy, which is considered a gold standard to stage for fibrosis, and elastography. And we'll talk a little bit more about this, but these three will kind of help us stage liver fibrosis or give a more complete assessment of where we are with those patients. Next slide, please. We're going to talk about the Medavir scoring, and this is a semi-quantitative classification system that actually consists of an activity score and a fibrosis score. In this slide here, you can see more about what we talk about the fibrosis score. Now, the activity score, it's usually graded according to the intensity of the inflammatory lesion, meaning A0, it's no activity, A1, it's mild activity, A2 is moderate activity, and A3, it's severe activity. When we talk about fibrosis score, this is actually going to be assessed on a 5-point scale. When 0 means no fibrosis, 1 is periportal fibrosis, 2 is periportal septate, 3 is bridging fibrosis, and 4 is considered cirrhosis. Now, this is often done for people with Hep C, but maybe also used for people with chronic hepatitis B, alcoholic liver disease, NASH or NAFL, non-alcoholic fatty liver disease, primary biliary cirrhosis, autoimmune hepatitis, or other metabolic diseases of the liver. Because right now we're more focusing on Hep C, this is something that we're going to be used to actually score the patients. Now, scores like Medavir may also predict who may be at risk of liver cancer. When we talk about hepatocellular carcinoma related to hepatitis C, as well as those with liver cancer who are more likely to have a recurrence after a hepatitis C treatment. Like most evaluations, Medavir is going to have its strength and its weaknesses. Small biopsies sometimes may not allow physicians to adequately determine a score representative of the whole liver. Remember that when we get a liver biopsy, we're only getting a small amount of tissue from the whole liver. And so sometimes there can be significant heterogeneity or variability of inflammation and fibrosis in different regions of the liver. The score will only reflect, and we have to be mindful about that it's only reflect that of the sample that we have obtained. And so in this way, the score may either overestimate or underestimate the amount of inflammation or fibrosis that is present at that time. Next slide, please. And so then it takes us to what do we use to stage liver fibrosis, right? And so that's when we talked about liver biopsies. So this actually has been considered, or it has been the historical gold standard to actually stage for liver fibrosis. Now, usually, to be honest, it's the gold standard will be considered when you have an explanted liver, and either with autopsy or following a liver transplantation, and you're going to have the whole tissue or the whole organ to evaluate. And as we're telling, because the architecture of the entire liver can be appreciated when we do that. Now, in clinical practice, cirrhosis is diagnosed with a liver biopsy, during which a sample of the liver will be obtained, and this can be either by a percutaneous approach, a transjugular, laparoscopic, or even a X-ray or radiographically guided fine needle approach. Now, the method for obtaining the biopsy will depend on the clinical setting. The sensitivity of a liver biopsy for cirrhosis is in the range from 80 to 100%. And it all depends also on the method that we use to get that tissue sample, and as well as the size and number of specimens that were collected. However, liver biopsy is not necessary if the clinical, laboratory, and radiologic data actually are very suggestive or strongly predicted that that patient may actually have cirrhosis. And of course, if the results would not alter the patient's management. And why we're mentioning that it's not necessarily needed to obtain is because we know that in some areas, we may have limitations to actually either have the specialist who will do the liver biopsy or the invasive natures of tests or costs that may actually prevent from that patient to get a liver biopsy. So we know that we can use other biomarkers, other imagings to actually give a diagnosis of cirrhosis if we have to, especially in areas where we don't have all the resources needed. Like,
we'll give Dr.
Next slide,
Cruz.
please.
Dr. Alfaro Cruz, it froze up for a moment. Well, we can keep moving forward.
Okay, perfect. So let me tell you about the indirect markers of hepatic fibrosis. And we have different ones that we have used throughout the years. And these are actually a series of serological biochemical tests that reflect alteration in hepatic function that do not directly reflect what's going
Dr.
on in
Alfaro
the
Cruz.
in the extracellular matrix metabolism. Now,
Dr. Alfaro Cruz, I think
hello?
you're still kind of cutting in and out. Is anyone else having difficulty hearing still? Dr. Alfaro Cruz. Okay.
I'll go ahead and
Looks
take
like we're
over.
Okay.
I'll go ahead and take over
Dr.
at this
Chesney.
point. We were very close to my handover, so I appreciate Dr. Alfaro Cruz kind of leading the conversation. She talked a lot about cirrhosis and the different stages of fibrosis that may be present, the impact it has clinically. And so what we just shifted into is what are the different ways that we can measure? And she just introduced a couple of different categories. So indirect markers of liver fibrosis are different laboratory markers that can be used to predict the amount of scar tissue based on studies that have looked at those numeric values and compared them to liver biopsy specimens. The first is an AST to platelet ratio index, which basically only looks at AST and platelet count. And depending on where you set the cutoff for that particular score, it can either be a moderately sensitive and moderately specific test for cirrhosis, or it could be a insensitive test, but very specific test, essentially depending on where you do the cutoffs. But it is a cheap and easy calculation to make. In addition, the FIB4 index is an additional tool that includes age, ALT, as well as AST and platelet count, that by adding those two additional relatively available tools, help improve the sensitivity and specificity, and more specifically, the negative predictive value, the positive predictive value. Essentially, if you have very normal AST and ALT levels, preserved platelet count, and a young age, your score is going to be relatively low, and that negative predictive value for advanced fibrosis can be quite high. On the other hand, if you have abnormally elevated ALT and AST, abnormally low platelet counts, and a more advanced age, that will correspond to a higher FIB4 count, and that higher FIB4 count corresponds to a higher likelihood of cirrhosis at present. But there is a wide range with this study where it's considered indeterminate. There's also a FiberSure assay, which is something that uses a proprietary equation and a prior study that looked at this data, and it's been recognized by many payers, but it doesn't necessarily add a lot of additional value. And depending on the individuals who use it, may feel it's no more accurate than APRI or FIB4 indices. I think, Dr. Alfaro Cruz, you are back with us. We could advance to the next slide if your connection is good.
So I think she's still having some challenges, it looks like. Okay.
Okay, I think I'm sorry for that. I think
Okay.
drop. Thank you, Dr. Chastain. So, and just to kind of completing what we were talking about, imaging, indirect biomarkers and liver biopsy, then we have elastography. And this is actually measures mechanical shear wave velocity, which is proportional to liver stiffness. So this is actually a we can use different methods. We can use a transient ultrasound, a transient magnetic resonance acoustic radiation force impulse that will actually help measure how stiff that liver is in order to give an assessment whether there's some reasonable degree of fibrosis or cirrhosis in that liver. And this actually may be a reasonable alternative to biopsy, especially in those areas where we don't have the luxury or the access to liver biopsy as easily to do. Next slide, please. Now, other ones as we're taking, really we're not going to, things that we have to know about anatomical imaging is that ultrasound, CT, or MRI may not actually be used for staging. They don't have enough sensitivity or specificity for underlying fibrosis. And if seen, advanced fibrotic changes likely correlate with pathology. So that's going to be more your gold standard. But these imagings can actually be useful to monitor for hepatocellular carcinoma, especially in those patients who have cirrhosis and have had treatment for Hep C. Next slide, please. Okay, Dr. Chastain, let me turn on to you so you can continue. Thank you for covering for that.
No problem. So what we're going to do is now pivot away from some of the foundational kind of conceptualization about what cirrhosis is, how it affects people's health, and also how we think about screening and staging liver fibrosis to actually how this applies in the practice. And I just want to call out the HCV simplified guidance again as a tool that can be used and highlight that while we often think about simplified guidance being oriented towards people without cirrhosis, there is an entire document, which is on the right side of the screen, about patients with compensated cirrhosis, and Mia just added a link to that in the chat box. Next slide, please. Within the guidance, there's actually information that builds on what we just discussed. Specifically stating that liver biopsy is not required for cirrhosis assessment, but there are different cutoffs that can be used with FID4, APRI, or even using basic platelet count, or if you have access to transient elastography with the measure of kilopascals. If any of those tests suggest cirrhosis, patients should be treated as if they have cirrhosis as far as selection of therapy, monitoring, and subsequent imaging for hepatocellular carcinoma. Next slide, please. When we actually talk about counseling patients after 12 weeks of therapy, some of this counseling is the same for patients without cirrhosis or those with cirrhosis. All patients need to be counseled that a hepatitis C antibody will be positive for the rest of their life, that reinfection is possible, and that future testing would require HCV RNA PCR testing or a similar test. However, how we manage patients are different. If before treatment they have no evidence of fibrosis, we may monitor them as if they were never infected. But patients with cirrhosis as part of their pre-treatment evaluation still warrant ongoing hepatocellular carcinoma monitoring, either with ultrasound every 6 months, CT abdomen with triple phase contrast annually, or an MRI abdomen with contrast annually. And in addition, patients with cirrhosis still may benefit from gastroenterology or hepatology evaluation for upper endoscopy for screening of esophageal varices. What's important here, however, is that treatment for hepatitis C is actually even more important among people with cirrhosis for reducing outcomes. So again, we don't want the perfect to be the enemy of the good. We don't need to put the long-term follow-up as a barrier to short-term treatment. Next slide, please. So again, I just want to highlight that document on the right, there is an entire guidance for patients to be treated with simplified guidance for those with compensated cirrhosis. Having cirrhosis is not a reason to avoid treatment in a variety of different settings. Next slide, please. I already highlighted some of the counseling a couple slides ago. And again, the simplified guidance has explicit guidance about patients with cirrhosis. So again, you can go back to that one-page guide, and the management of how you do things differently with patients with cirrhosis is laid out for you as well. Next slide, please. Now, this has all been in the frame of talking about patients with compensated cirrhosis, meaning that they have scar tissue in their liver that is severe enough that qualifies as cirrhosis, but that they have preserved liver function, enough preserved liver function to do the main functions of the liver. But decompensated cirrhosis is really what we call symptomatic liver disease that goes everywhere from mild symptoms to overt liver failure and liver-associated mortality. And the physical exams findings that may be associated with this would be hepatic encephalopathy or mental slowing due to accumulation of toxins that are usually processed by the liver, or ascites, additional fluid that has escaped the intestines and into the vascular space into the intra-abdominal peritoneal cavity, where patients may have swollen abdomen and also may also present with lower extremity edema. Additional laboratory abnormalities that might be seen in patients with decompensated cirrhosis would be an elevated bilirubin, a low albumin, and an elevated prothrombin time, or INR, signifying an increased risk of bleeding. Paradoxically, those patients also are higher risk for thrombosis as well. There are calculators that can help us classify and predict whether patients have decompensated cirrhosis or not, but those should only be used and applied to patients with cirrhosis. Child-Jacob-Pugh scores or MELD scores are not accurate in patients who don't have the fundamental underlying diagnosis of cirrhosis. Next slide, please. Speaking of that, a Child-Jacob-Pugh score is a clinical score that was really originally developed for predicting operative mortality for people with cirrhosis. And you can see the scoring system is that by going through the point scale, every person gets a minimum of 5 points, if not 6 points, based on the different enumerations for encephalopathy, ascites, bilirubin, albumin, and prothrombin time. If you have a score of 7 to 9, that would classify as class B or decompensated cirrhosis. And if it's scored 10 to 15, that would qualify as class C, decompensated cirrhosis. And again, that is a tool that can be used to help determine whether a patient has compensated or decompensated disease. Next slide. A MELD score is different. This is used for organ allocation for adolescents and adults age 12 years or older. And this includes bilirubin, sodium, INR, creatinine, as well as dialysis status. This can be used to help predict 3-month mortality, particularly among patients with decompensated cirrhosis, but also other medical complicated factors. And this is a scoring system that's often used for determining if a person qualifies for transplant listing and also how high on the transplant list someone may be placed. The next slide, I have no particular expertise in, but we can move to. And Dr. Alfaro-Cruz added this, and this is basically highlighting that there is a different score for pediatrics for children under the age of 12. This includes albumin, bilirubin, INR, but it's 2 different factors, age of listing as well as growth failure. And there's a couple of different calculations and highlights here, but what's often pivoted here is not only post-transplant survival and waiting list survival, but also life years gained subsequently, which is really significant when we start thinking through the impact of transplant populations. And Dr. Alfaro-Cruz, you have experience in this space, so I'll let you speak to the utility of PELD scores and why it's so important.
Yes, because in actually in children in less than 12 years old, growth failure and the age of listing has a significant great impact on what's going to be the life year gain expectancy after that. And so this actually is going to make us put those kids higher on the list for transplant, for liver transplantation. Whether they get a PEL score more than 28, they just go on top of the list. Will kind of put them at a increased risk for liver decompensation if we don't get a transplantation sooner. So this is what in kids younger than 12, the PEL score has a great impact. And 2 of the things that actually gain more in terms of gives you more points is if you're actually not growing and not gaining weight, which is something that we don't tend to see in the adult world being as important as we do in the PEL score.
Thank you for that. We can move on to the next slide. And just want to highlight a couple things. We talked a lot about the importance of treatment of patients with cirrhosis, but I do want to highlight the treatment of hepatitis C in patients who have liver failure or decompensated cirrhosis The impact of that strategy is less certain. We do know that hepatitis C treatment reduces MELD scores, and I presume PELD scores on patients with decompensated cirrhosis, but mortality benefit of treating patients who already have developed liver failure is unclear. Liver transplant is clearly the best treatment for hepatitis C-related decompensated cirrhosis, and so if a patient has decompensated disease, they really need to be evaluated in a liver transplant center. In patients who have no access to transplant, treatment may be considered. It's also important to highlight that liver transplants now often are coming from hepatitis C positive donors, and hepatitis C is treated post-transplant. So we're not saying that we won't treat patients with hepatitis C and decompensated cirrhosis. It's just trying to time the treatment most appropriately to help them with their medical condition. Next slide. This just highlights a research article of 868 patients with cirrhosis from 4 hepatology clinics. 64% experienced clinical progression over the period of time in the study. Sustained virologic response was associated with survival in patients with compensated cirrhosis, but not with patients who had already developed liver failure. And 19% of patients who were decompensated liver failures had improvements in their MELD score after treatment, but their mortality did not differ. What that really means is that if they were listed for transplant, they were less likely to get a transplant because their MELD score had improved, yet their mortality related to their disease did not appear to change. We are still awaiting more definitive studies to describe the impact of hepatitis C treatment and decompensated cirrhosis, but thus far, it's very clear that preventing liver failure is the most important element. Next slide. If we do decide to treat patients with decompensated cirrhosis after discussion with a liver transplant center or assessment of access, treatment is traditionally with ladipsir sofosbuvir for genotype 1 through 6 or sofosbuvir velpatasvir for genotypes 1 through 6, along with weight-based ribavirin, which allows us to shorten the therapy to 12 weeks. However, if a patient's ribavirin ineligible, we can look at the next slide and highlight that we can use these same 2 regimens without ribavirin for 24 weeks. So we can move to the next slide, and the table that's listed there simply shows that if you're not going to use ribavirin, we have to go with a longer course of therapy. I believe that the next slide, which we can move to now, is simply highlighting that there are certain regimens like glecaprevir pebrinsvir, which are not recommended in patients with decompensated liver failure, as well as medication regimens like sofosbuvir velpatasvir, voxilaprevir, because protease inhibitors are predominantly metabolized by the liver. And when patients have decompensated liver failure, class B or class C, Child-Jakob score cirrhosis, those patients have increased adverse effects and should only be treated in the context of an expert with those regimens. Last but not least, we can move to the next slide, which gives us, I think, an opportunity and a pause for questions from the audience. We had a lot of content between Dr. Alfaro-Cruz and I, but happy to take an echo pause here for people to unmute and ask a question, or you can add a question to the chat box.
Hey, this is David Kershke.
Hey, David.
Hey, so I think you kind of discussed this, but I had written down as a question. We have had several, so I'm at the health department clinic up here in Northeast Tennessee, and we've had some patients with decompensated cirrhosis that really had no alternative to get treated in another setting, where ribavirin would be an option, or, by a, specialist. And just in discussion with specialists, have decided to put people on like a 6-month regimen. And the 2 that I know of did seem to do well. Can't tell you about mortality. I don't think either of them have died, but I don't know that we've kept following them. But they did have symptomatic improvement with the treatment, and they did have response to the treatment. So
I think it's a very important comment and allows me to kind of jump in. And I would agree with your management practice and your approach. In my clinic, I often care for patients who are, even though I work at a transplant center, I take care of patients who cannot access those services or don't qualify for those services. I take care of a large number of people who actively are using substances, and that might be a reason that they are not eligible for transplant for a prolonged period of time, or they might be uninsured or underinsured and not have access to specific resources. In those patients, I disclosed to them that treatment of the hepatitis C may or may not impact their overall outcome, but it is one therapeutic thing that we can do along with symptom control to try to improve their outlook, partly because we don't know the long-term outcomes. Anecdotally, I have had several patients treated with decompensated cirrhosis or liver failure who have had significant symptom improvement and actually have recompensated and have done well over several years. I've also had patients on treatment whose liver disease progressed that despite hepatitis C treatment died as a consequence of their liver disease. I think that my suspicion, and this is my personal anecdote, I can't quote data, I think there are individual patients who likely do benefit from hepatitis C treatment, but there are other patients who do not. I think discerning that in large data cohorts is very difficult, and it'll probably take time for us to determine who are the patients who are likely to benefit from this. Not, but in clinical practice, if I have a patient with decompensated cirrhosis who cannot access transplant evaluation or transplant, I do discuss treatment. If I cannot manage ribavirin effectively, I do exactly what you mentioned. I treat them with a sulfoxaflor-based regimen for 6 months or 24 weeks, and then try to support their disease otherwise. Great comment. Other questions or comments? Thank you.
That's really interesting. Go ahead.
I think we can move on to the cases, because I think the cases might illustrate some of the things that we talked about.